but why don't we get started? So Dr. Wade Christopher is going to be presenting prognostic indicators for undifferentiated carcinoma with and without osteoclast-like giant cells of the pancreas from a large database review.
Thank you for the opportunity to present. I'm Wade Christopher. I'm a fellow in surgical oncology at Providence St. John's Cancer Institute in Santa Monica, California. We have no disclosures for this discussion, so this was a paper with the data coming from the National Cancer Database. Looking at undifferentiated carcinoma of the pancreas, it's divided by the WHO into two subgroups, those with osteoclast-like giant cells and those without. Of the ones without, you have anaplastic carcinoma not otherwise specified, giant cell carcinoma, pleomorphic large cell carcinoma, and sarcomatoid carcinoma. We looked at the predictors of decreased survival in these patients, and we found that older age and non-surgical management portended a worse prognosis. You can see the graph here depicting the use of surgery. We also saw that increasing tumor stage portended a worse prognosis as well, and having something other than R0 resection and a poor histology showed decreased survival as well. Looking specifically at surgical resection margins, you can see the difference in overall survival for those with osteoclast-like giant cell R0 versus R1 and R2, and then the non-OCLG R0 versus R1 and R2. Overall survival, looking at from the multivariable analysis, we saw that those with osteoclast-like giant cells had a longer median overall survival compared to those without, as depicted by 24.8 months versus 3.8 months, with a hazard ratio of 0.52. When looking at the subtypes of the non-osteoclast-like giant cell, we found that the pleomorphic large cell had the worst survival at 2.4 months, followed by giant cell carcinoma and sarcomatoid carcinoma. And the longest was anaplastic, not otherwise specified, but again, this was only 4.5 months. So in conclusion, osteoclast-like giant cell histology is associated with improved survival compared to those without osteoclast-like giant cells or anaplastic, regardless of stage. Of the non-OCLGC subtypes, pleomorphic large cell was associated with the shortest overall survival. Surgical resection does provide a significant survival advantage for all histologies in early stage cancer. And for patients undergoing surgery, R0 resection provides a significant survival advantage. Thank you very much.
Any questions?
I have a question.
Yes.
Can you tell me, based on this, what are you doing differently with these patients? Can you diagnose this before, or this is only on pathology, like on your biopsies beforehand? You don't know what the differentiation is, and are you doing anything different with neoadjuvant or adjuvant therapy?
So I think yes, you can see this on the diagnosis as far as your biopsy. As far as neoadjuvant, that's more difficult because there's no specific regimen that's proposed for this subtype because it is so rare. I know the shift is towards neoadjuvant in almost all settings of adenocarcinoma, but this is different. I think best as we can tell, achieving an R0 resection provides the best surgical advantage with a less clear role for which adjuvant or neoadjuvant chemotherapy to use.
Any other questions? Okay.
Thank you.
Thank you.
Thank you for being exactly on time. All right, I am going to announce, do patients with normal ejection fraction on hepatobiliary HIDA scan benefit from cholecystectomy? And this is Dr. Webb from Mayo, Arizona.
Great. Good morning. So HIDA scans with calculation of ejection fraction is the mainstay in the diagnosis of biliary dyskinesias. And within that family of dyskinesias, that a hypokinetic gallbladder has previously been defined with ejection fraction of less than 35 or 38%. And this is based off of the distance of standard deviations from the mean in a small cohort of patients. More recently, the hyperkinetic gallbladder has been described with its diagnostic threshold at above 80%. So the objective of our study was not so much to validate this number, but instead to look for the upper limit of a normal ejection fraction above which patients would benefit from a cholecystectomy. So to do so, we performed a retrospective review of all HIDA scans with ejection fraction at our facility from the years 2007 to 2020. We excluded any patients found to have stones, sludge, or HIDA scan with ejection fraction ordered for an inappropriate reason, such as cholecystitis. Other pathology was also excluded. And then our primary outcome was symptom resolution in terms of postprandial epigastric or right upper quadrant pain, and then nausea and bloating at the last known follow-up. After exclusions, we had almost 3,000 patients with HIDA scans with ejection fraction. And 2,089 of those were patients with ejection fraction of over 40%. In this group, the mean was 79.9% ejection fraction, while the median was 84%. So we looked at patients with ejection fraction above 70%, which was almost 1,600. And in this group, about 9% had a cholecystectomy. And ironically enough as it is, there were only 2 cholecystectomies performed in the group with 80 to 85% ejection fractions. And we were unable to detect a significant difference, or a significant trend, I should say, in symptom resolution at higher ends of ejection fraction. But in conclusion, the average gallbladder ejection fraction in patients with acalculous biliary symptoms approaches the current diagnostic threshold for biliary hyperkinesis. And patients without evidence of cholelithiasis who experience biliary symptoms may still benefit from a cholecystectomy. Ejection fraction data should be interpreted in concert with other clinical and subjective findings to determine candidacy for cholecystectomy. Thank you.
Thank you, and we'll take any questions. So I'll ask a question. So how are you using this clinically? I struggle with HIDA scans a little bit because I think the symptoms in the patients are often not typical. So how are you dealing with patients who have atypical symptoms who have an abnormal HIDA scan?
I mean, we don't have an algorithm or a protocol by any means, but once again, it's very individualized. When patients presenting with classic symptoms, it's easier to kind of make that decision to perform a cholecystectomy, but atypical, I think that they often require a little bit further workup, whether it's a GI colleague or what other upper GI pathology. But we try to control for that in reviewing patients with EGDs and excluding those. So.
Okay, any other questions? All right, thank you. Next talk, a needs assessment for palliative care curriculum development in surgical residents. Dr. Jennifer Geiger, University of California, Davis.
Surgeons are frontline providers of primary palliative care, yet most residents do not receive formal training in these skills. We administered a needs assessment to define our current learning environment. A survey was distributed to general surgery residents last December. It assessed palliative care training and clinical experiences, as well as their perceived skill level and associated learning priority for 26 core palliative care competencies using 5-point Likert responses. Responses for competencies were averaged across all respondents and graphed within a 4-quadrant grid using a method called importance performance analysis. Each quadrant carries implications for future curriculum design. 37 residents completed the survey for a 51% response rate. Approximately 2/3 were female, representative of our program, and residents from all training levels participated. 73% had cared for more than 10 dying patients. 76 had led at least one family meeting, but of those observed by faculty, 43% indicated they had never received any formal feedback on their performance. Here, selected competencies are shown in the IPA grid to highlight how it can facilitate identification of curricular priorities. Let's just focus on a few in the communication domain that are highlighted in yellow. Skills in conducting family meetings could be an area to concentrate on. Delivering bad news was the highest importance to residents, despite them rating high performance levels in this domain. Skills in advanced care planning, though lacking relatively based on self-report, may require more creative strategies to engage learners as they are of lower importance to them. In conclusion, residents at a tertiary institution would benefit from a curriculum that treats palliative care skills like procedures and provides residents the practice they deserve. These findings will guide the creation of a meaningful competency-based program. Thank you.
Any questions?
Karen Bratzel from Portland, Oregon. We've done a similar needs assessment using a different methodology and found that one of the things our residents identified was that they had been exposed to these skills in an inpatient world, but that in an outpatient world, particularly an oncology, surgical oncology world, they had not been exposed at all. I'm curious both as to whether you assessed the location and then what do you plan to do about this?
I remember having a conversation with you about this previously, actually, and I didn't assess the differences in clinical environments. Our trainees face that similar situation where primarily our training is in the inpatient setting. Since I identified communication domains as high priority, and I believe advanced care planning is important, I think some of the communication tools I've identified, by making them applicable to the inpatient setting, but ones that are diverse and that can then still be utilized in those outpatient settings, you can still build that skill set and just kind of reframe it and allow them to see the breadth that they can use those skills in.
And how do you foresee, what kind of curriculum would you recommend then for the surgical residents? Would it be something in the sim lab, or would it be a class, or?
Yeah, I think the communication piece is one of the most important things, and it needs to be sim-based. I'm currently developing one that utilizes the serious illness care program. It has a communication guide that is kind of more directed for advanced care planning, and some use of standardized patients to allow at least some role play and practice with those skills.
Okay, thank you very much.
All right, our next mini oral 6 is actually virtual, so it's only available on the app. So we're going to go to Dr. Joseph from the University of Nevada, and he's going to talk about intraoperative video assessment of surgical skills as a useful tool for resident training in a community setting.
Thank you very much. Video-based assessment is used more and more for laparoscopic and robotic cases. The technique is used in resident training is for residents to be able to assess their skills using the already set standards of OPRS, gears, and goals. This is a video-based assessment that we instituted into our program. It leverages a couple of areas of expertise, including artificial intelligence, as well as external peer review. The residents are provided a scoring metric within their OPRS gears mechanisms. They also are given side-by-side video assessments between themselves and expert content, and they are also given an online blog version in order to interact with the external experts to get better feedback. This allows for, in a community program setting, an opportunity for the leadership to assess not only the residents but also the faculty and assess whether those residents are getting adequate training. This is one of the screenshots of what the resident would receive, including feedback, a scoring metric. Below, they have side-by-side video comparisons. The things that we identified to be useful is that it is a viable tool not only for the resident training, but also to assess faculty in terms of their ability to teach and the roles that the residents play in those cases. It allows for the residents to gain feedback not only externally, but also get video and direct evaluation of their technical skills. We did note that there was disparity between our local faculty and the faculty online in terms of their assessments. However, this could be explained by the fact that the faculty, video faculty or expert faculty, are only grading a very specific aspect of a case rather than the entirety of the case. Finally, we think it's a very useful skill that can be used in conjunction with simulation to better train residents. Thank you.
Question.
I have a question as to how much time this took. We discarded this due to the amount of time we felt it would take to edit the video and then the amount of faculty time, so I'm curious as to how much time it took.
Yeah, so ours is a little bit unique. So we don't do the editing. We have an external company that does that. So the residents, how they do it, they put in their name, the faculty name, and the case. They press record. They can do that 10, 15, 20, 30 minutes before the case. At the end of the case, they hit finish. They are then given the opportunity to sign, or whoever did each aspect of the case, and they hit upload. And on the back end, the company is able to edit it completely down. It's fully HIPAA compliant as well. So it takes about an extra 2 minutes, maybe at most, in the operating room. And afterwards, they get their assessment within about 6 hours, sometimes up to 12 for the AI part, and then about 24 hours before the expert. And
What about the
What does
cost?
it cost?
Great minds think alike.
ditto. So there are a couple different versions of this. The cheapest version that I've seen, and there are multiple companies that do this, so I'm not pitching any one, is about anywhere from about $100 to $300 per assessment, and we can kind of set the number of assessments. There are cheaper versions. Our version is about $25,000 for the entire year, and that includes every resident plus as many assessments as they would like. The cheaper versions, you can plug a thumb drive into the back of your laparoscopic tower or your robotic tower and just do it yourself and upload, and then, yes. And if you're doing your own video editing, it's totally painful. I would suggest you hand that over to an AI company that does it for you. So. Sorry? Two parts. Number one, being in a community setting, the faculty that we use are not the same academic quality as academic surgeons. So the assessment that a community faculty provides me as a program director is very discordant to what I would consider to be an adequate assessment of a resident and their skill set, especially when you talk about year-to-year progression, especially in a new program where the faculty has not really trained a lot. Number two, I can tell you that in the setting of the simulation center, where the budget is pretty substantial, right? We have a ton of high-cost simulators and other things that we have to buy as a program. You can actually trim some of those bells and whistles on many of the simulators and get the price down.
Okay, thank you very much.
Thank you.
Very interesting. All right, MO8 will be available on the app. We're going to move on to MO9, development of a scoring system to predict hernia as the cause of groin pain. Dr. Desmond, I can't say your last name, I'm sorry, Beverly Hills Hernia Center.
Hi, morning. My name is Des. I'm one of the residents at Cedars-Sinai in Los Angeles. Today I'll be sharing some of our work on making a scoring system for predicting hernia as a cause of groin pain. The story really starts with this hernia health questionnaire, which we've been using for quite some time now. It's a 50-item questionnaire, which is a detailed look at patient symptoms, and all patients who are being evaluated for inguinal hernia in our practice routinely complete it. It's pretty granular, it's a pretty detailed characterization, and we've been using it for quite some time. From 2013 to 2020, we collected data on all our primary inguinal hernias and had a very high response rate. We wanted to see if we could use some of the details collected from this questionnaire to correlate any relationships between preoperative symptoms and patient outcomes. Something we had noticed in this data set is that while the vast majority of patients did get better after their operation, 15% of patients did not and may have had groin pain secondary to some other etiology. So with this 15% in mind, we wanted to see if we could use the data from the questionnaire to help us with this diagnostic challenge. After a lot of kind of trial and error experimentation, testing different modeling methodologies, we came up with the following model. It's a logistic regression-based model that uses all 50 of the hernia health questionnaire items as covariates to predict whether or not patients will have resolution of symptoms after their operation. The model had good performance in predicting the data set, as you can see, relative to the performance benchmarks for AUROC and Breyer score. And just for reference, here's a comparison of our model's performance to the NISQIP surgical risk calculator, which we see used regularly. As you can see, the 50-feature logistic regression performs kind of at the high end compared to the NISQIP calculator and its various components. So in summary, we validated this 50-feature hernia health questionnaire as a predictor of resolution of symptoms after inguinal hernia repair. Thank you very much.
Any questions? So I'm a breast surgeon. I haven't done hernia surgery in a while, but why is it that 15% of patients don't get resolution?
Well,
of
yeah,
their
that
pain?
number, oh, sorry. Thanks for that question. Yeah, that number was interesting to us as well, and I think it just kind of goes to show that there is a need for kind of a more granular diagnostic to help us guide which patients should and should not get an operation. I think a lot of these patients had pain from hip or other pelvic etiologies, and were kind of being put into the group of patients who were thought to just need a hernia repair.
I see. Another question?
Yes, John Russell from Albuquerque. Did the accuracy of your scoring system vary at all with either the anatomy of the hernia or the type of repair performed?
We're looking into that right now. We have identified some early trends, but keep an eye out for that in our next publication.
Hi, Lee Newmeyer from Jacksonville, Florida. That was a great study and a good use of your data. So 2 questions. Number 1 is, what are you going to do with the data now? Are you not going to repair hernias if their symptom score is such that it predicts they won't have resolution of their symptoms, or you just use it for counseling? And the second question is, was there, I couldn't see because it went by really fast, the 50 things. How many of those are actual pain? Because I think if you operate on pain, you usually get pain. So, thank you.
Right. Thanks for that question. Yeah, so certainly our next steps are going to be to kind of make this score available to help with patient engagement, help other referralists decide whether or not they should see or refer their patients to a surgeon. The next step, just in terms of calibrating the scoring system, would be to see what's better, our clinical judgment versus our just plugging it into our calculator and seeing who has a better positive predictive value. In terms of the symptoms that we look at, there is a fair amount of looking at pain, but there's a lot of atypical symptoms that I think a lot of us don't necessarily ask during our hernia evaluation. I think that's where the kind of true value of this really detailed characterization lies.
Thank you.
Thanks.
All right. Moving on to the mini oral 10, clinical patterns, predictors, and results of endograft limb occlusion following EVAR. And Dr. Nahirniak is going to present from Henry Ford.
Thank you. So our study was a retrospective review of patients over an 18-year time period from 2000 to 2017 at 2 different community-based hospitals in Michigan who underwent EVAR. These patients were surveyed postoperatively with physical exam, CTA, and duplex imaging. Our goal of the study was to assess incidence and risk factors of endograft limb occlusion of these patients following up. Mean follow-up of these patients was 8 years. So we had 369 patients that were treated with EVAR over that 18-year time frame. 319 patients were able to be fully analyzed, 6 had incomplete imaging, 4 mortalities, and 40 were lost to follow-up. Of these 319, 22 patients had endograft limb occlusion, 20 had supported grafts, and 2 of 4 patients total treated with unsupported grafts had limb occlusion. Looking at these patients overall, we kind of assessed all the vascular comorbidities, CAD, hypertension, diabetes, renal failure, and tobacco abuse. No differences between the thrombosis group and the non-thrombosis group. No difference in mean age and gender as well in the 2 groups. And then some anatomic factors that were similar that we thought may have a factor in terms of leading to limb occlusion. Size of aneurysm was not significant. The angulation at the bifurcation of the aorta to the common iliac, in addition to the bifurcation of the common iliac to internal and external iliac, the angulation did not make a difference. In terms of timing, of the patients, the 22 patients that had occlusions, 3 occurred within 1 month, which we defined as early. Median follow-up, 1 to 12 months. 12 patients had limb occlusion at that point, and 7 were late, 1 to 5 years out. And here's our data. I highlighted in red the statistically significant factors leading to limb occlusion: small diameter common iliac size, which we defined as less than 6 millimeters, graft extension into the external iliac, and then prior stenting of the common iliac. So our conclusions, predictors of endograft limb occlusion include unsupported graft, small diameter common iliac artery at the landing zone of the distal end of the graft, graft extension into the external iliac, or prior common iliac artery stenting.
Okay,
Thank you.
thank you.
Any questions?
Questions?
When you have patients who have your risk factors, how are you dealing with those surgically? Are you doing anything differently?
So potentially offer them like an open repair if need be, or potentially put them on antiplatelet or anticoagulation going forward.
And are these patients routinely followed up to 8 to 10 years, or what's the protocol?
So you typically get like yearly follow-up at least with like duplex, just to follow up looking for endoleaks and things like that.
Okay, thank you very much.
Thank you very much.
We'll go on to the next MO11, assessment of predictors of hospital utilization after liver transplant, implications for value of care delivery. Dr. Sheckley, Mayo Clinic, Arizona.
Good morning, everyone. I'm actually a medical student at Midwestern University. This project was done in the Mayo Clinic in Phoenix, Arizona. We have no disclosures. So liver transplantation, as we know, is a complex procedure. It comes with a lot of comorbidity risks for the patient, especially with patients with a lot of comorbidities. The US readmissions, they are more frequent with liver transplant, reach up to 50% in some centers. They frustrate the patients, the caretakers, and their families. They also had more cost, and they add more congestion and burden to the institutions. So we wanted to determine some recipient donor perioperative factors that might predict these early hospitalization after liver transplant, especially in the modern high-volume centers that utilize some high-risk organs from donation after cardiac death with DCD that we use quite often at Mayo. So also to determine if these readmissions have some long-term outcomes on these patients, and also we conducted a retrospective data reviewing the patients in our EMR specifically at Mayo Phoenix between 2016 and 2018. So we had a total of 344 patients. About 45% of these patients were readmitted in the first 90 days. The majority of those were about 32% were readmitted within the first 30 days, which is a little bit below average for the readmissions within that period of time. About 62% were readmitted with one readmission, and then about 37% had more than one readmission within these first 90 days, as we can see right here in the graphs. The risk factors that were associated that we saw with like donation after cardiac death, basileximab induction, which we use exclusively for patients with renal dysfunction because of renal sparing characteristic, and also the patients with increased initial length of stay at the hospital and recipient diabetes. Those were predictive factors. However, in multivariate analysis, the basileximab induction were predictive of early readmission within 30 days and 90 days, and recipient diabetes were associated with significantly greater odds of readmission within the first 90 days. And as far as the long-term outcomes, the patients were readmitted within the first 90 days, and any number of times have a higher graft failure compared to patients who are not readmitted. And the patients with multiple readmissions in the first 90 days actually had even more graft survival compared to the single readmissions patient. So in conclusion, we wanted to show that diabetes and renal dysfunction represented by the basileximab inductions were notable predictors for early readmission for after 90 days, which importantly in DCD, liver transplantation was actually not associated with multivariate factors when accounting for other factors with early readmission. With the long-term outcomes that we have shown, we wanted to emphasize the importance of reducing these in order to identify these patients in order to reduce some of these long-term outcomes. Thank you.
Okay, thank you. Any questions?
What are you doing now with these patients? So you noticed that Simulect or basileximab is a problem. Are you not using that anymore? We use it in all patients who have any sort of renal impairment.
Yeah, no, this is not to say that the basileximab induction itself is a cause of, but because we use it for patients with renal dysfunction as a renal sparing characteristic. So, this is just sort of a retrospective study that we did, but definitely looking further or things to improve these readmissions is with patients with diabetes, better glycemic control, more follow-up, maybe even with like the, the virtual platform that we have, so maybe increase the follow-up to these patients, and also increase the use of other renal sparing medications for these patients with AKI to hopefully reduce these readmissions.
And what about social determinants?
This is
Yeah.
definitely also a factor, and I've seen like some other studies who have the patients who live farther, they provided some help with providing living close to the hospital within the first couple of weeks after the liver transplantation, and again, increase sort of the follow-up with these patients to make sure that they do come in for their post-operative checks.
Okay, thank you very much.
Thank you.
All right, we're moving on to MO12, incisional hernia rates between intracorporeal and extracorporeal anastomosis in minimally invasive ileocolic resection for Crohn's disease. And Dr. Collini from Mayo Clinic Rochester is going to present.
Good morning. I would like to thank you for moderating and thank you to the Western Surgical Association for the opportunity. My name is Giacomo Carini. I am an Italian resident and a visiting research fellow in colon and rectal surgery at Mayo Clinic Rochester. 1/3 of patients with Crohn's disease require multiple abdominal surgeries during their lifetime. Ileocolic resection is the most frequent operation and usually the first in patients with Crohn's disease. For this reason, it's crucial to reduce incisional hernia rate after ileocolic resection. The aim of this study was to assess incisional hernia rate and postoperative outcome for minimally invasive ileoconic resection for Crohn's disease. In this retrospective cohort, we compare patients undergoing intracorporeal anastomosis with fanesteel incision versus extracorporeal anastomosis with midline vertical incision. All preoperative characteristics explored were similar between the two groups. Intracorporeal with fanesteel group showed lower incisional hernia at the extraction site after a median follow-up of 15 months. Likewise, a time to event analysis showed a 4-year incisional hernia rate of 20% for extracorporeal anastomosis with midline vertical incision. Also, length of stay was shorter in the intracorporeal group with similar 30-day readmission rate. In addition, there was no difference in overall postoperative complication classified by Clavi and Dindo and in wound complication between the two groups. In conclusion, strong consideration should be given to performing intracorporeal anastomosis with fanesteel incision during ileocolic resection to reduce hernia risk in patients with Crohn's disease. I'd be very interested to hear comments and questions. Thank you.
Questions?
Hi, Shirin Tofai from Beverly Hills. Thank you for doing this study. I think that many others have also shown that where you remove your specimen has a lower incisional hernia rate if done as a fanesteel than as a periumbilical. That's been shown in urology for prostates and multiple colorectal studies. But what you're doing is you're correlating your anastomotic procedure with the incisional hernia, implying that you should just do intracorporeal anastomosis. But are you making it, are you just correlating it? Because I feel that it's really where the incision is that matters, not how you do your anastomosis. I understand there's a correlation, but to actually put the two together seems a bit
Thank you so much for your question. The reason that this is a retrospective cohort and our usual practice is either intracorporeal anastomosis with fanesteel incision or extracorporeal with midline vertical incision. Because in Crohn's disease, usually you have thick mesentery and you cannot perform really an extracorporeal anastomosis using a fanesteel incision. So this is the reason between, we would like to show, the difference between the two groups. Thank you.
Great, thank you.
Thank you.
So the next, that's you. Pardon me.
We'll go to MO14. Is PRIME a sufficient tool for evaluation of student clinical competency on a surgical clerkship? Dr. Ratmeyer from University of New Mexico.
Good morning. I'm a fourth-year medical student at the University of New Mexico, and today I'm going to be talking about clinical clerkship evaluations for medical students. The objective for this research was to analyze trends in clerkship grading and the differing emphases between internal medicine and surgery clerkships, and to investigate whether the prime evaluation that we use at our institution was appropriate for covering specific areas of emphasis between these two clerkships. Here's an example of our prime evaluation that we use. It consists of 5 categories, each with subcategories that are graded between 1 and 4 points. The methods for this were retrospective review. We looked at prime evaluations both quantitatively and qualitatively from both the Department of Surgery and Department of Internal Medicine. Clerkship reviews, we then split these evaluations into different groups based on their mean and their variance. Low mean, low variance was thought to include areas that might have more systemic issues at play. Low mean, high variance was thought to be a proxy for where evaluators were looking most specifically, and high mean, low variance thought to be an area where evaluators had maybe lower points of emphasis. If we look at our results here, there was a pretty clear delineation both in mean and variance between the surgery clerkships and the medicine clerkships. In general, across all the clinical competencies, the surgery clerkships had higher means and lower variances, indicating perhaps lower points of emphasis, but these trends switched when we got to the professionalism components of the evaluation. So communication, humanism, and integrity and work ethic were thought to be high importance areas for a surgical clerkship. So in conclusion, when we viewed these prime evaluations in aggregate for both clerkships, there were no systemic issues found. However, the specialties differed in their emphasis between categories, and the surgical clerkships had more emphasis on professionalism. The surgery clerkship may benefit from a more nuanced evaluation, and the clerkships in general may benefit from either a wider scoring range or just grading based on competency based on the heavy skew towards the upper limit of the 4-point scale.
Thank you.
Thank you. Any questions? How would you use these findings then to change the surgery clerkship?
Yeah, I think that at least trialing methods that are being used in residencies and in some medical schools with just competencies, or expanding our survey to include more questions on the surgical clerkship dealing with areas of work ethic, professionalism, that sort of thing.
There's one other question.
Just
if
one
it's
quick question.
Yeah, sure.
How come the surgeons had 40% more evaluations, or approximately that? Were they
Yeah.
just more professional at returning them?
No, so we did see that, and while the surgery clerkship had significantly more evaluations completed, the evaluations themselves were less fully filled out, and that's just based on the clerkship, the nature of the clerkship. On internal medicine clerkships, you're working with an attending for a week, 2 weeks at a time. Whereas on the surgery clerkship, you might see an attending maybe once or twice, and they might never have an opportunity to have you take a history in front of them.
Thank you.
Thank you.
All right, we're running a little bit behind, so we're going to keep moving here. The next talk is, does ACR T1 RAD score correlate with the stage and extent of thyroid cancer? And this is Dr. Wang from UT Southwestern Medical Center.
Hey everyone, my name is Ben. I'm a third-year medical student at UT Southwestern. I appreciate the opportunity to present to you all today. Today I wanted to talk to you all about our project on the ThyRAD staging system for thyroid cancer. Thyroid cancer affects greater than 40,000 people annually in the United States, a great source of morbidity. The ThyRAD's risk stratification system was originally developed to determine which thyroid nodules would warrant biopsy based on ultrasound findings. And so the aim of our study was to determine if ThyRAD scores did indeed correlate with the extent of cancer in patients with histologically confirmed differentiated thyroid cancer. And we did this by staging thyroid cancers and comparing staging thyroid cancers with the AGES and the MACES prognostic scoring systems. We determined their associations with pre-biopsy ultrasound ThyRAD scores. Overall, our study included 120 patients with papillary thyroid cancer as the most common subtype of cancer. Lymphovascular involvement was present in 30% of these patients, and these tumors demonstrated higher TI-RADS scores compared to tumors without lymphovascular invasion at 4.6 versus 4.3. However, this did not reach statistical significance. Overall, our study demonstrated that higher TI-RADS scores may affect lymphovascular invasion in thyroid cancers. Furthermore, high-risk tumors demonstrate strong correlation with TI-RADS scores, and in the future, we'd like to expand our cohort to better understand TI-RADS as a tool for preoperative thyroid cancer screening and its role in preoperative planning. Thank you.
Dr. Prinz.
Yeah, Richard Prince, North Shore. So you have a study where you exclude more patients than you're actually looking at. Does that speak to having just a select group of ultrasonographers looking at this as a quality measure? Because, I mean, if you have the whole array of all those ultrasonographers at Southwestern, I'm sure you're going to get the variability you're showing.
Right, so most of the patients that were included in this study were done by a single ultrasonographer. We tried to reduce the variability by having multiple readers for the ultrasound readings to keep consistency in the study.
Okay, thank you.
Thank you.
So MO16 is virtual. You can look at it on the app. We'll go to MO17, outcomes of incidental appendectomy at the time of abdominal operations, analysis of the NISQIP database. Dr. Gebram from Wyckoff Heights Medical Center.
Thank you for the opportunity. I'm one of the second-year residents at Wyckoff. So I have no disclosures. This study is set in the recent literature of the results of the CODA trial and all the European literature that's inviting us to look more into the personalized or patient-centered allocation of appendectomy. And the way we define incidental appendectomy is just as a prophylactic appendectomy rather than going in the abdomen, finding an inflamed appendix and treating that. And the literature has been suggesting some benefits of that prophylactic appendectomy in certain populations. Looking at 3 years of the NSQIP database, we isolated the appendectomy as a secondary procedure to a primary abdominal operation, and that was kind of a liberal definition, excluding some procedures where appendectomy may have been performed as a therapeutic procedure. We reached a very small number of incidental appendectomies, and that was our conservative definition. Most of these surgeries were either a hernia repair, lysis adhesion, or cholecystectomy. In the univariable analysis, we found some associations with our three main outcomes, which were surgical site infection, length of stay, and major complications, which were higher with the addition of an appendectomy as compared to the primary procedure alone. And on multivariable analysis, using logistic regression, we found that that was also corroborated and after adjusting for all these factors. This study has multiple limitations, which are related to its design. And so in conclusion, 1 to 8% of all appendectomies in that database were performed in addition to another procedure, and there may be a worse 30-day outcome with the addition of that procedure. This has implication on informed consent, and the role of prophylactic appendectomy is a research gap that should be addressed in future studies. Thank you.
Any questions?
So should we ever really be, oh, we have a question here. Go ahead.
Do you really think adding an incidental appendectomy to another major abdominal procedure increases in complications and length of stay and the other things that you notified? Or is this a marker? Is this just an association that maybe if somebody had a more extensive operation, didn't want to go back in that abdomen because it was so messy that they added an appendectomy or cholecystectomy, so it's just marking a different patient population?
Correct, yes. That was an unadjusted confounder in our study, and a lot of these surgeries may have been done for like high-risk patients that are already predisposed to high risk of complications.
Great, thank you.
Just a quick question. So the short-term outcome is a little worse you're showing, but I mean, the point of doing it is to prevent something from happening in the future. Do you have any long-term outcome of whether these patients, prevent having an appendicitis versus, what they would have had without it?
Not in this study.
Do you have a crystal ball?
Yeah, I do not, but there have been studies that have shown some advantages, like an advantage of preventing future appendicitis in patients with. Like just taking it out creates a zero likelihood of appendicitis, and not taking it out is associated with a small percentage of appendicitis.
Thanks.
Okay, thank you.
Thank you.
Next, we're going to have Dr. Sky Mayo from Portland, from Oregon Health and Science University, and he's going to talk about liver first resection and synchronous colorectal liver metastases is associated with inferior recurrence-free survival, a propensity-matched analysis.
Good morning. Thank you for welcoming me as a new member. I have no disclosures. Upwards of 40% of patients present with synchronous disease. Unfortunately, this is becoming increasingly more common in our younger patients as there's a delay to diagnosis, as we heard from Drs. Kuram and Obaid yesterday. Traditionally, these patients were managed in a primary first approach with plans to address the liver disease later. The driver of overall survival, however, is metastatic disease of the liver. So a liver first approach and also a simultaneous resection have come to the fore. The METASYNC trial, published in 2021, randomized patients with synchronous disease to a simultaneous resection or to a primary first delayed approach. The 2-year overall survival favored simultaneous resection. However, this trial was limited as the liver first strategy wasn't considered at the time the trial was formulated. Our preferred approach at OHSU has been a liver first or a simultaneous resection if possible over the past decade. However, we have seen a decrease in recurrence-free survival associated with liver first resection. We investigated our institutional data comparing the liver first strategy where the primary is left intact as compared to a primary first or simultaneous resection where the primary cancer is removed early on. To answer this question and account for the significant imbalance in patients managed with the 3 strategies, we created a propensity match cohort comparing a liver first to a primary first or simultaneous resection. The 34 patients in each group were well balanced after propensity matching. The liver first approach was associated with a shorter recurrence-free survival driven by a higher extrahepatic disease recurrence at 3 years. Notably, this did not translate into a difference of overall survival at 3 or 5 years. In conclusion, the liver first strategy does remain a viable option as compared to a simultaneous or primary first approach, but it is associated with an increase in extrahepatic recurrence and shorter disease-free interval. That does not translate into an overall survival difference in our cohort. We believe the future of managing patients with synchronous disease will be a tailored approach, taking into account next-generation sequencing, functional imaging, and using assays such as ctDNA to assess for molecular residual disease, to stratify these patients into the timing of the management of the primary to ultimately reduce the risk of extrahepatic recurrence. Thank you all for your attention. I'd be happy to take any questions.
Natalie Johnson, Portland, Oregon. And my question would be the conclusion that liver first resection may be ultimately not different, but I wonder if you include the quality of life of patients. If they have sooner recurrences, probably means more therapy and maybe a lesser quality of life. So what do you think about that?
Oh, thank you, Dr. Johnson. That's a great question. I would actually like to acknowledge Dr. Tom Sutton, who's sitting there in the front, who was the author on this manuscript as a new member I was presenting. Yeah, I mean, it's a big thing. I mean, if you can do a simultaneous resection, you can get the patient through in one operation. There's a risk of delay to any type of adjuvant treatment if there is a complication. As for a liver first approach, while they may have extrahepatic disease recurrence, usually that recurrence is not as symptomatic and now can be treated with other modalities. So, the liver-derived survival is kind of the message right now. I think the work is to be able to address in a thoughtful and quality of life manner the extrahepatic recurrence that is higher with that.
Okay, thank you very much. Move on to MO20, immunonutrition is not associated with benefits in a post-pancreatic duodenectomy outcomes. Dr. Wang from Loyola.
Hi, good morning. So malnutrition is a significant risk factor for poor prognosis as well as poor outcomes in patients undergoing a PD. Immunonutrition, specifically those formulated with arginine, glutamine, as well as nucleic acid, has been widely used perioperatively for colorectal patients. The evidence for immunonutrition use in PD patients has been very sparse as well as mixed. So at our institution, we retrospectively looked at 344 patients with periampullary malignancies. These patients either had a normal diet leading up to surgery, or they received 5 days of preoperative immunonutrition impact. The outcomes that we looked at included length of stay, infection rates, and then postoperative outcomes such as delayed gastric emptying and postoperative pancreatic fistula. So with our univariate analysis, we see that there are some characteristics between the patient cohorts that exist, including sex as well as the pathology distribution. In terms of our outcomes, we didn't see any significant difference between length of stay, but we did see an increase in the rate of intra-abdominal infections as well as pancreatic leak rates. However, we saw a decrease in the rate of delayed gastric emptying. We then performed a one-to-one propensity score matching analysis using the nearest neighbor method. Here we saw that the characteristics between the two groups disappeared, and the 136 patients, each of the groups were well matched. Despite the matching, we saw that there was still an increase in the rate of intra-abdominal infections as well as pancreatic leak, and we continue to see the decreased risk associated with delayed gastric emptying. We further went on to do a multivariate analysis looking at our specific targets of interest. In terms of delayed gastric emptying, we saw that higher BMI is associated with an increased likelihood of delayed gastric emptying, whereas pathology, specifically non-pancreatic adenocarcinoma, and the use of immunonutrition are associated with a decreased likelihood of patients developing delayed gastric emptying. In terms of the postoperative pancreatic fistulas, we saw again that patients who have non-pancreatic adenocarcinoma as well as use of immunonutrition are associated with an increased risk of developing postoperative pancreatic fistula. So in summary, our study showed that immunonutrition did not have a significant impact on length of stay for patients. Intra-abdominal infection rates were higher in patients who received immunonutrition versus a regular diet preoperatively. And then patients who received immunonutrition were less likely to develop delayed gastric emptying. However, that patients who received immunonutrition were more likely to develop a clinically significant post-operative pancreatic fistula, even when we control for the differences in pathology. So our conclusion is that this is still, receiving immunonutrition preoperatively is still a routine practice at our hospital institution, but should we continue to do this? Thank you.
Questions?
Thank you for your study. When you were matching, did you match towards reconstruction, pyloric sparing versus classic, and did you classify people on the fistula risk scale and then also match them that way?
Yeah, that's a good question. So we actually did not match based on the surgical technique. Over the last 15 years, there were about 4 different surgeons at our institutions who performed Whipples. So for the most part, their techniques were the same. So that was not something that we control for that, but that would be a good thing to look into.
Great. Thank you very much.
Thank you very much.
We'll move on to the next presentation, COVID-19 disease and solid organ transplant recipients, multi-center analysis of 2,000 cases. Dr. Calderon from Mayo Clinic, Arizona.
All right, good morning. Thank you for the opportunity to present.
You're going.
So COVID-19 disease has been associated with significant mortality and morbidity in these patients. Reports on outcomes in solid organ transplant recipients have been mixed. We performed a retrospective observational analytic study. We collected data on reported COVID-19 cases among solid organ transplant recipients, followed at 3 of the high volume academic transplant centers that Mayo encompasses over a year. We identified these cases via direct treatment at either of these 3 centers, queries in the electronic medical record, and or reported outcomes to the center by patients directly. So we had a total of almost 2,000 COVID-19 cases reported in our solid organ transplant recipients. Of these, about 1,800 presented to one of the 3 transplant centers encompassed by Mayo, and we have a breakdown of what these transplants were. Of the 1,500 patients that received medical treatment, 68 received convalescent plasma, 17 received antivirals, 9% were enrolled in clinical trials, and 6% received other modes of therapy. Almost 500 patients required a hospital admission at one of the 3 Mayo Clinic hospitals, and 110 required an ICU stay with mechanical ventilation. And of these patients, 13 required ECMO. Our median hospital and ICU length of stay was 9 and 11 days respectively, and was proportional to age. Mortality for all of our patients was about 9%. And 57% of our COVID-19 related deaths occurred more than 5 years after transplant, but a significant percentage occurred early, within 1 year or less after solid organ transplant. So here we have a distribution of all the diagnoses. This is not broken down into individual or different kinds of transplants, but we can see that they're pretty similar. As far as the deaths by years post-transplant, we can see a significant increase in the deaths of patients after 5 years of receiving their transplant. Most of these patients were diagnosed from November 2020 to January 2021, and the higher incidence of deaths were pretty similar in distribution. So in conclusion, COVID-19 carried a significant morbidity and mortality in solid organ transplant recipients in this multi-center case series. Late post-transplant mortality was significant. Given the structure of the study, the burden of disease is likely greater than what we had recorded. And during the study, or during this time period, vaccines were not commercially available throughout the entire study, and vaccination status was unknown at the time. So these data have implications for preventing and managing COVID-19 disease in solid organ transplant populations, and this will help in guideline development as well as clinical trial design. Thank you very much.
Any questions? Do you have a comparison to other transplant centers or just COVID-19 patients in general?
Unfortunately, at the time where we performed the study, we didn't compare it to other national centers.
I think there's a question at the mic.
Hi, Austin Shank from Ohio State. Has the Mayo Clinic interpreted these data to say that outcomes are enough worse in solid organ transplant recipients to justify a mandate for vaccination in waiting candidates?
Well, we have seen that, there's no real, at the time that we had no real vaccination status or any studies on that, but nowadays all of our transplant recipients are getting vaccinated, and they're even getting their 3rd booster, but Mayo Clinic has not dictated anything as far as mandating vaccination.
Thank you.
Thank you.
Okay, we have 5 more to go, and we are supposed to be done at 7:45, but let's keep going. Usefulness of intraoperative parathyroid hormone monitoring and guiding autotransplantation in reoperative or subtotal parathyroidectomy for primary hyperparathyroidism. Dr. Richards, Mayo Clinic, Rochester.
Thank you. I'm a second-year medical student at the Mayo Clinic in Rochester, and I have no disclosures. Our study was really rooted in, how do I go back? Okay. Our study was really rooted in 3 main ideas. The first being that autotransplantation of excised parathyroid tissue is frequently done following parathyroidectomy. The second is that there's little data to guide surgical decision-making on when to autotransplant. And third is that parathyroid hormone is frequently monitored intraoperatively during these surgeries. We also want to note that autotransplant success rates have previously been reported as between 82 and 99%. So we aimed to determine if intraoperative parathyroid hormone monitoring can be used to guide decision-making for autotransplantation. We began with 278 patients with primary hyperparathyroidism who received autotransplantation following parathyroidectomy for reoperative or subtotal hyperparathyroidism. We stratify these patients based on follow-up data into groups of candidate or not a candidate for autotransplantation, and we did this by following their parathyroid hormone values over the next month. We then analyzed the data for intraoperative parathyroid hormone kinetics, demographics, and outcomes. Between these groups, there were statistically significant differences in parathyroid hormone levels across all data points, and these were by parathyroid hormone at specific times or percent drop by certain times. Of our 159 patients who had complete data sets, only 21 or 13% were classified as candidates, and of these, 10 autotransplants failed. As the goal was to create a predictive model, ROC curves were created for each of our data sets, and we identified 2 criteria that were able to determine with 100% sensitivity which patients were at risk for permanent hypoparathyroidism. However, this was done with a low specificity. In conclusion, IOPTH drops are significantly different among candidates and non-candidates. Utilization of IOPTH to predict all patients at risk of permanent hypoparathyroidism would require liberal use of autotransplantation, and autotransplant tissue viability into subcutaneous tissue is much lower than previously reported. Thank you.
Any questions?
I'm curious as to why you chose to do your autotransplants into subcutaneous tissue. This is not an area of surgery that I've done in many years, but I know in the past we used to put it into brachioradialis muscle. So why, with better blood supply, so why autotransplant into subcutaneous tissue?
That has been the standard at our institution, and that's the way it's been done for many years, and unfortunately I could not tell you exactly why that decision was made.
Thank you very much. We better move on. So the next talk from Dr. Wu from North Shore University Health System is on pressure difference between preoperative distal esophageal peristaltic amplitude and impedance planimetry balloon pressure after fundoplication predicts patient quality of life.
Good morning. Laparoscopic fundoplication is a surgical management for gastroesophageal reflux disease. However, patients suffer from postoperative side effects such as dysphagia and gas bloat. Patients with abnormal esophageal motility may suffer at a higher rate of these postoperative side effects. Manometry and impedance planimetry. Esophageal manometry, shown here on the top, can characterize the peristaltic wave by measuring the length, duration, and force of the peristaltic wave. Shown here, the catheter is in the gastroesophageal junction, and the contractile vigor of the peristaltic wave is also known as the distal esophageal peristaltic amplitude. On the bottom, the impedance planimetry, through the use of the functional lumen imaging probe, can measure the dimensions of the gastroesophageal junction and calculate the tightness of the gastroesophageal junction, known as the distensibility index. It can also measure the intraluminal balloon pressure at the gastroesophageal junction. So, our aims were to examine the strengths of peristaltic wave, the distal esophageal peristaltic amplitude, overcoming the hiatal outflow resistance of fundoplication on the gastroesophageal junction. So we hypothesize here that a smaller difference between the two pressures leads to a lower postoperative quality of life. So we did a retrospective review with, we also analyzed patient-reported outcomes. So what we found were 3 different pressure difference groups, a difference of less than or equal to 15, 16 to 79, and a difference of greater than or equal to 80, and found that at 1 year, patients with a difference of greater than 80 had the best reflux symptom index score, indicating the best management of atypical GERD symptoms. And here's our conclusion.
Okay.
Great. Are there any questions?
Any questions?
Is this routinely done for most patients that have this operation, or?
So in terms of, laparoscopic fundoplication at North Shore, we used the flip system to measure the dimensions of the gastroesophageal junction to understand how the dimensions are modified after the operation. So we're learning how the operation modifies the dimensions to correlate that to patient-reported outcomes.
Thank you.
You're welcome.
MO24 is available on the app. We'll go to MO26. Open conversion of endovascular aneurysm repair is associated with worse survival in late aneurysmal rupture. Dr. Ellisad from University of California, San Diego. You have to run so we stay on time. I'm just kidding.
Good morning, everyone. Thank you for the opportunity to present our study entitled Open Conversion of Endovascular Aneurysm Repair is associated with worse survival and late aneurysmal rupture. I have no disclosures. Endovascular abdominal aneurysm repair have replaced open aneurysm repair as the procedure of choice for abdominal aortic aneurysm. However, significant rates of late reintervention and aneurysmal rupture was found, resulting in the need for conversion from EVAR to open repair. Therefore, we aim to compare perioperative and long-term outcomes between patients undergoing open conversion from EVAR to patients undergoing primary open repair in the Vascular Quality Initiative database linked to Medicare claims. Usual statistical methods were used. Over 4,000 patients were included, with 8% undergoing conversion. Patients with conversion were older, more likely to be symptomatic, and with medical comorbidities. They also had larger aortic diameter and higher use of preoperative anticoagulants. At 30-day, conversion was associated with higher risk of perioperative mortality and renal complications. At 5 years, conversion was associated with high risk of all-cause mortality, aneurysmal rupture, and reintervention. These results also persisted after 10 years of follow-up. So in conclusion, conversion to open abdominal aneurysm repair is associated with significantly higher risk of perioperative morbidity and mortality compared to primary open abdominal aneurysm repair. At 5 and 10 years of follow-up, conversion was associated with significant increase in mortality, aneurysm rupture, and reintervention. These results support performing primary open aneurysm repair in those patients who are medically fit for surgical intervention. Further work is needed to improve identification of patients who may be at high risk of conversion to open repair following EVAR. Thank you.
Any questions? It's just very impressive that you have 10-year follow-up data.
Yeah.
I think that's really great.
I think you're doing the next presentation as well, are you? All right, so we're going to keep her up here, and she's going to tell us a bit about the impact of COVID-19 on vascular surgery case volume.
I have no disclosures. According to the recommendation of American Board of Surgery during the initial phase of COVID-19 pandemic, access to surgical care was limited to urgent and emergent cases only. So we aim to analyze the impact of COVID-19 on elective and urgent vascular surgery case volume across different vascular procedures. The Vascular Quality Initiative database was investigated for several vascular procedures. We compared monthly case volume as well as total urgent cases for each procedure between 2019 and 2020. Our cohort included a total of 177,000 cases. 51% were performed in 2019, and 48% were performed in 2020. During January and February 2020, there was an increase in the number of cases for all procedures compared to 2019. However, from March to May 2020, all procedures suffered significant reduction compared to 2019. The highest reduction was observed during April. During May 2020, the gap in case volume started to decrease. The highest fluctuations were observed for open abdominal aneurysm repair, peripheral vascular intervention, and carotid endarterectomy. A sub-analysis based on urgency showed significantly higher case volume for urgent cases during 2020 compared to 2019 for carotid endarterectomy, carotid artery stenting, TEVAR, and peripheral vascular intervention. So in conclusion, COVID-19 pandemic has severely impacted vascular surgical care, especially in peripheral vascular intervention, open aneurysm repair, and carotid endarterectomy. The impact of delay on patient outcomes is still unknown, and future studies are needed. However, this study provides an insight into the areas of vascular surgery that are most susceptible and can help identify vulnerable populations, so preventive measures can be taken in case of similar future events. Thank you.
Any questions? Did the Vascular Society publish any guidelines about which cases to delay or not delay or anything like that during the?
They just recommended delay of elective cases. So any elective cases were delayed, but urgent and emergent cases were going on. There is no specific procedure.
And it looks like maybe the case numbers haven't quite gotten back to the pre-pandemic levels. Is that?
Yes, after May, yeah.
Okay, thank you.
Great, thank you.
All right, the last abstract, MO29, postoperative opiate utilization and prescribing patterns in living kidney donors. Dr. Calderon, Mayo Clinic, Arizona.
That's not my presentation.
Okay.
Can we,
MO29.
MO29?
There it is.
All right, thank you, and good morning again. I'll be presenting postoperative opiate utilization and prescribing patterns in living kidney donors. No disclosures. So living kidney donors become exposed to opioids during their routine post-surgical care, and this may lead to adverse outcomes. Since there is no prescribing guidelines at the time for this population, with this study we aim to determine patterns of opioid utilization and prescription among living kidney donors across our 3 transplant centers. So as we know, living kidney donors are a globally healthy population. Just in 2019, there were about 21,000 kidney transplants in the US, and around 6,000 were performed from living donors. In 2017, there were about 47,000 deaths from opioid overdose, and 36% were related to opioid prescriptions. So we performed a retrospective review from 2014 to 2017. We had a total of almost 900 patients at our 3 academic transplant centers. We had a total of 837 opioid-naive patients and 26 tolerant patients. And we determined that the oral morphine equivalence, the standard would be 200 for either laparoscopic or open nephrectomies. We see that we had no significant differences in our demographics among the 2 groups. As far as a length of stay, we see that postoperative length of stay was significantly, statistically significant, longer for our opioid-naive patients, closer to 2 days. And we can see that opioid-naive patients, 99% of them required a OP prescription at discharge. 11% required a refill as compared to 8%. The median oral morphine equivalent for opioid-naive patients was 225 as compared to 150. And 60% of our opioid-naive patients required greater than 200 oral morphine equivalents after surgery as compared to 31 in the opioid-tolerant group. So in conclusion, opioids are still widely overprescribed for patients undergoing donor nephrectomies. Opioid-naive patients require a higher amount of oral morphine equivalents and are prescribed more opioids than refills. And so novel guidelines for prescribing opioids for these patients in pain management are needed. Thank you.
I have a quick question. Do you have a standardized protocol for these patients post-operatively? We instigated a sort of an ERAS several years ago, and so we minimize opiates and add muscle relaxants and other things to, and bowel regimen and that sort of stuff. And secondly, any difference between lap and robotic donor nephrectomies in pain?
So at our center, we perform donor nephrectomies with urology and transplant. Our transplant surgeon performs only laparoscopic hand assist, and urologists do robotic. Unfortunately, with the urologist side of the nephrectomies, we don't have control over how much narcotics they prescribe, and we don't have comparable data at this time.
Okay.
Okay.
Thank you.
Thank you. We
Great
are
job,
done.
everybody. Thank you.
We're going to take a 5-minute break.